Good afternoon. Thank y'all for coming today. For those of y'all that I have not met, my name is Ethan Pippin. I'm a pharmacy resident here at UMMC. I'm from ULM. So for those of y'all that I haven't met, it's nice to meet y'all. To get started, a little bit of background. The journal that I'm going to be talking about with y'all today was the initiation of antiretroviral therapy in early asymptomatic HIV infections. So data from randomized trials are lacking on the benefits and risks of initiating antiretroviral therapy in patients with asymptomatic HIV virus who still have a high CD4 count of more than 350 cells per cubic millimeter. So basically what this trial was looking at is for patients that are presented that are treatment naive, that still have high CD4 counts, so well above 5, 6, even 700. What was to be the best time as far as evidence-based medicine to really start antiretroviral therapy? So evidence for initiation of antiretroviral therapy in patients of more than 350 cells per cubic millimeter comes mainly from the results of observational studies. And so this right here was a good way for us to really have a study that was focused not on starting initiation when they were absolute CD4 count was 200 or 300 or 400, but even 500 and 600 in the higher ranges, just to kind of fill those gaps of evidence that we have for this. As far as the generalized study overview, the study site, it was conducted in 215 clinics in 35 countries. So a very diverse population was included in this study as far as different race, nationalities, different countries, where also you have different opportunistic infections that seem to be more prominent. So for that was, I felt, a very strong suit of this study. As far as the funding, it was from the National Institute of Allergy and Infectious Disease and others. As far as others, it does not say who those others are, but that the National Institute of the Allergy and Infectious Disease was the primary donor for this study. As far as the trial designed, it was a randomized study. It was not blinded in the sense that the patients or the study, the people performing the study, they did not know, it wasn't blinded to them. They knew if they were receiving treatment or not. Obviously, there was no placebo or anything of that nature given. But all the people that performed the data and the statistics and the calculations, they were blind to which group the population was in, whether if it was immediate initiation or delayed initiation of therapy, which we'll get into further later on. As far as the null hypothesis, is they were thinking that there is no benefit in initiation of antiretroviral therapy in newly diagnosed HIV patients with a high CD4 count of greater than 500. The objective of this study was to determine the risks and benefits of the immediate initiation of antiretroviral therapy in asymptomatic HIV patients who have a CD4 count of more than 500 cells, as compared with deferring initiation of treatment until their CD4 count reaches a level of 350. As far as methods, HIV positive patients, this was the inclusion criteria, they had to be 18 years of age or older. They had to be treatment naive, so never receiving any kind of antiretroviral therapy. They had to have no history of AIDS and were in generally good health, minus having HIV. So, and they had to have those qualifications to be eligible for this study. As far as exclusions, patients were excluded if they were pregnant or breastfeeding, but it is also important to note that if they became pregnant during the study, they were allowed to remain in the study. As far as the independent variables, the immediate initiation group was started on antiretroviral therapy at the beginning of the study, regardless of CD4 count. So it didn't matter if it was 600, 700, they were started automatically. With the delayed initiation, they did not receive antiretroviral therapy until their CD4 count was less than 350 cells per cubic millimeter. The primary endpoint was a composite outcome that included two major components. The first was any serious AIDS-related event, and when they refer to AIDS-related event, they're looking at tuberculosis, recurrent pneumonia, Hodgkin's lymphoma, invasive cervical cancer for females, cryptococcal meningitis, CMV, and along with others is what they were considering to be an AIDS-related event. And that also included death from AIDS-related events as well, as long as any of the AIDS-defining illnesses that I just listed. The second component was any The second component was any serious non-AIDS related event, including death from causes other than AIDS, and that was looking at other diseases such as cardiovascular disease. That included stroke, MI, death from cardiovascular disease, end-stage renal disease, dialysis or renal treatment or renal replacement therapy, liver disease as far as decreased liver function, or death from liver disease was considered non-AIDS related events. The secondary efficacy endpoint included serious AIDS-related events and non-AIDS related events and death from any cause. And then also they looked at grade 4 events, and grade 4 events were classified as life-threatening symptomatic events that were not caused by AIDS that required hospitalization, was classified as a grade 4 event. As far as statistical analysis, the trial compared the two study groups according to the intention to treat principle. Though they never did state in the study what methods they used in the intention to treat, if they were carried forward or how that was done, they simply just stated intention to treat. The trial used time to events methods, including the Kaplan-Meier survival curves and Cox proportional hazard models, to compare the two groups for the primary endpoints, which was death from any cause and other serious clinical events. For the primary endpoint, the hazards ratio were used with 95% confidence intervals that were estimated from a Cox model stratified according to the 6 geographical regions with a single binary indicator. And those 6 regions go back to where this was in 35 countries that this study took place. Those geographical regions were like Africa, Europe, Israel, North America, South America, Mexico, and Australia and Asia as well. The statistical analysis were performed with SAS software version 9.3, and all p-values were two-sided in this study. As far as the results for this study, there was a total of 4,685 patients who were enrolled for the trial, and they were followed for an average of 3 years. This was enough to sustain was enough to have power for this study, which I think it was calculated they needed 4,600. There was 2,326 and 2,359 patients. They were randomized into immediate initiation or deferred initiation groups, respectively. The median CD4 count was 651 cells per cubic millimeter upon initiation of the study. The primary endpoint occurred in 42 patients in the immediate initiation group, which was 1.8%. 0.6 events per 100 person years, as compared with 96 patients in the deferred initiation group, 4.1%, 1.38 events per 100 person years, for a hazard ratio of 0.43 with a 95% confidence interval, 0.3 to 6.2 with a p-value of less than 0.001, so this was statistically significant between the two groups. And then also the hazard ratio for serious AIDS-related and serious non-AIDS-related events was 0.23 with a 95% confidence interval and a p-value of less than 0.001, and 0.6 with a 95% confidence interval with a p-value of less than 0.04, so all of those being statistically significant. The risks of grade 4 events, though, were similar between the two groups. This is also important to know that no matter when the initiation of therapy was started, even though you did see an increased benefit as far as AIDS-related events and other adverse events, there was no documented case of decrease in hospitalizations. So that is one aspect that you can look from this trial, is there was no difference in the amount of hospitalizations that were associated with earlier initiation of ART therapy. As far as the author's conclusions for this study, the initiation of antiretroviral therapy in HIV-positive adults with a CD4 count of more than 500 cells per cubic millimeter provided net benefits over starting therapy in patients after the CD4 count had declined to 350 cells per cubic millimeter. Now, with that being said, I would also like to add that it ended up in the actual study, the average CD4 count of the deferred initiation of therapy for the patients was actually 408, and I wasn't sure if I covered that or not, and I would like to make that known. And the reason they say that, well, Ethan, I thought you said they had to have a CD4 count of 350 before they were started. Well, they also had other reasons for initiating ART in the deferred group. And that also came back as if they had a serious non-AIDS event, or if they had other clinical or event diagnosis, or if they had a rapidly declining CD4 count. So just to let you know that 350 was not a hard number. The actual number of the average CD4 count was 408, I believe. So with that being said, they actually, for the majority of them, started ART in much sooner than 350. So I also did want to make that known. I think I forgot to mention that. As far as my critiques of this study, the purpose of this study, I felt it was clearly stated. The study procedure and design were clearly outlined. It was a very large international randomized study, and it's always, I feel it's important that when you're talking about such a global disease, especially like of HIV, that it's always very important that you include different areas of the world. Different opportunistic infections could therefore, could change the way that we practice and the way that we monitor therapy. And so I felt that that was a very strong suit. Also, another great that I felt was a very good pro of this study was that when they randomized the patients into immediate initiation versus deferred initiation, the groups were extremely similar on all fronts as far as the amount of males versus females, race, other peoples that had other risk factors. For cardiovascular disease risk factors, they even narrowed it down to where the same amount of people that had those risk factors, it was very equal between the two study groups. And so I thought that that was very important, that they were very similar in that sense. The Independent Data and Safety Monitoring Board reviewed the results of the interim analysis. So this study was actually cut short because it was found to have answered the primary question, which was time to an AIDS-related event or non-AIDS-related event, comparing these two groups. So that kind of leads into another sense, is in the average study time of these patients was about 3 years. So in a sense, that still doesn't answer some of the questions that we may have for long-term therapy, as far as the sense that when people start ART, normally they're going to be on it for the rest of their life. And so you're looking at 20 or 30 years, where this study only followed the population for an average of 3 years. So as far as the really long-term effects, the negative side effects of these different medications, and how that relates to 10, 20 years, this study really didn't answer that because it only followed the patients for an average of 3 years. And part of that was because the study was stopped early because it felt like that the study questions had been answered, that it was beneficial to initiate therapy regardless of CD4 count in a higher CD4 population and a higher count, which was pretty significant. The study investigators were unaware of the summary results, so whenever they were documenting and they were recording all of these results, the study investigators were not aware. So that was a sign of, I felt that was important, that they were unaware of the numbers that they were getting and how they were affecting treatment. Overall, I felt that the study was organized and set up in a very good way. I think that it definitely answered the question that it set out to answer, which is with patients with a high CD4 count of 500, 600, 700, which I think the average in this one was 651, versus waiting to some type of adverse AIDS-related event or related to a lower CD4 count. I felt that it did answer the study question, and I felt that it was set up appropriately and that it was worked out very well. Do I have any questions, or do you have? I have lots of questions. Do you have any questions? Yes, sir.
What should help us to do responsibly? How should that change our practice?
Well, to my knowledge now, most of the practitioners still, it's still, we practice in the sense that it is, they still initiate ART as soon as they're diagnosed. So as far as what we do here, to my knowledge, all practitioners, they start therapy as soon as they can. So as far as what we do here, it's not necessarily going to change how we practice. I just felt that since when the CDC guidelines, they talk about the different when to start, and they do recommend starting earlier, but they do admit that there's kind of a lack of evidence as far as it's more opinion-based, clinical experience, some other trials, but kind of observational. So this kind of reaffirms what we were thinking, and this was a really good trial that really just kind of put the nail in the coffin for that as far as what's the best way to go about these treatments. Yes, sir.
So obviously there was direct benefit to the patient.
Right.
Thinking beyond the patient, why else would you be a proponent of starting ART early?
Okay, say that again. I'm sorry.
So knowing that we've got a direct benefit to the patients, so lower mortality, lower infections, et cetera, what else, thinking beyond the patient, would you use as a push to say we probably should be doing
Right.
this?
Definitely, I think that comes to where helping decrease the rate of the spread of the disease. So that's also something that they didn't really talk about that much, but obviously that would be also a very big point to always bring to argue your point that regardless of CD4 count, you would want to start antiretroviral therapy strictly on the basis that it can help decrease the rate of transmission, therefore helping everybody. Okay. Thank y'all. Appreciate it.